In the next section, we'll look at an overview of carbohydrate, protein, and vitamin absorption in the GI tract. In the next section of the GI physiology module, we'll be looking at carbohydrate, protein, and vitamin absorption. All carbohydrates need to be broken down to monosaccharides before they can be absorbed. Salivary amylase, or ptyalin, and to a larger extent pancreatic amylase digests starch into alpha-limit dextrins, which contain 5 to 9 glucose monomers, maltose, maltotriose, and alpha-1,4-linked malto-oligosaccharides, which have between 4 and 9 glucose units. Food also contains trehalose, lactose, and sucrose. In order to facilitate further digestion, we have brush border oligosaccharidases. These reside in the brush border, as the name suggests, and are present in the epithelium of the duodenum and the jejunum. The alpha-dextrinase or the isomaltase hydrolyzes the alpha-1,6 linkages at the branch points. Maltase hydrolyzes maltose into true glucoses. Glucoamylase hydrolyzes malto-oligosaccharides into single glucose units. Trehalase hydrolyzes trehalose into 2 glucoses. Lactase hydrolyzes lactose into glucose and galactose. Lactase is important because this is one of the most common causes of intolerance found in the patient populations. Patients will often come and complain about problems when they drink milk. This is often due to lactose deficiency. The important thing to remember clinically is this is related to the volume of milk drunk. Therefore, patients with lactase intolerance or lactase deficiency will have problems with cream and may not have problems with 2% or skim milk. Sucrase, another brush border oligosaccharidase, hydrolyzes sucrose into glucose and fructose. Glucose and galactose are taken up by the transport protein SGLT1 or sodium glucose transport protein 1. They are taken in along with a glucose gradient, and transport is facilitated from the lumen to into the epithelial cell. They are then absorbed into the blood via the GLUT2 receptor. Transport of fructose from the lumen into the epithelial cells is mediated by the GLUT5 transport protein. Carbohydrate malabsorption is caused by a deficiency of one of the oligosaccharides. They can be congenital or acquired later in life. Patients present with diarrhea, bloating, and flatulence. So if you get this constellation of symptoms, consider asking about carbohydrate malabsorption as part of your history. Patients will have an osmotic diarrhea because these oligosaccharides are osmotically active. Colonic bacteria can break down some of these oligosaccharides, increasing the number of active particles. They also break them down, and this results in the production of intestinal gas, further contributing to flatulence. Protein digestion is started in the stomach with the release of pepsin from chief cells in the form of pepsinogen. This yields various sized polypeptides. An ingested protein is almost completely hydrolyzed and absorbed by the time a meal has traversed the jejunum. After the stomach, pancreatic proteases play the major role in protein digestion, and this results in small peptides and some amino acids. Subsequently, just like with carbohydrates and the presence of brush border oligosaccharides, there are aminopeptidases, carboxypeptidases, endopeptidases, and dipeptidases in the brush border of mucosal cells that liberate amino acids. Some of these di- and tripeptides actively can be transported into enterocytes and can subsequently be hydrolyzed by intracellular peptidases. On the left-hand side, we have a brief overview of protein digestion. Protein that enters the stomach is digested by pepsin, into amino acids and oligopeptides. This task is continued by pancreatic proteases such as trypsin, chymotrypsin, elastase, carboxypeptidase A, and carboxypeptidase B. Subsequently, with the oligopeptides, there are peptidases in the brush border that break them down further. In addition, di- and tripeptides can be absorbed and are broken down by intracellular peptidases. They can then be absorbed into the bloodstream in the form of amino acids, as shown in the right side of the diagram. It's important to remember that only L amino acids are absorbed. There are at least 4 different sodium amino acid cotransport systems, and these are for acidic, basic, neutral, and imino amino acids. Di- and tripeptides require a hydrogen gradient for absorption, and this is set up by the sodium-hydrogen exchange pump. As far as export from enterocytes is concerned, there are at least 5 transport systems, 2 of which are sodium dependent and 3 of which are not. Amino acid absorption in the duodenum and the jejunum is rapid and slow in the ileum. However, it should be recognized that by the time a meal has been ingested, most protein will have been absorbed by the time a meal crosses from the jejunum into the ileum, and this may explain from an evolutionary perspective why amino acids are absorbed less rapidly in the ileum. There are a number of protein disorders that are clinically relevant. Cystinuria is a disorder where there's a co-transport of a cysteine, lysine, arginine, and ornithine, which is absent in the small intestine and kidney. The mnemonic for this is COAL, C-O-A-L, which represents the 4 different amino acids, and this results in cysteine in the urine and feces. Patients present with cysteine kidney stones, as the other amino acids that are resorbed, namely lysine, arginine, and ornithine, do not create crystals in the urine. This is an inherited autosomal recessive disorder. Vitamins such as the fat-soluble vitamins A, D, E, and K are absorbed with fat and included in chylomicrons as they are absorbed. Therefore, if there is in disorders such as A-beta lipoproteinemia, where there is impairment of chylomicron absorption, you will also have impairment of absorption of the fat-soluble vitamins. Most water-soluble vitamins such as B1, C, biotin are sodium dependent. B2 absorption is increased by bile salts, and B6 absorption occurs by simple diffusion. B12, as has been mentioned earlier, requires intrinsic factor from parietal cells and is absorbed in the terminal ileum. In the absence of intrinsic factor, patients will present with B12 deficiency. It's important to remember the different types of vitamins and how they're absorbed, as these are things that can easily be tested in the exam. The most important questions will probably relate to pernicious anemia or to the fat-soluble vitamins A, D, E, and K. With vitamin absorption of B12, B12 requires intrinsic factor from parietal cells. So in this schematic, B12 is bound to food. In the stomach, in the presence of low pH, free B12 is released. This rapidly binds to R protein and is degraded, free B12 is released when R protein is degraded. B12 then binds to intrinsic factor, and the two together are absorbed in the terminal ileum. This combination of intrinsic factor and B12 is subsequently taken to the liver for further processing. In the last section, we looked at carbohydrate, protein, and vitamin absorption in the GI tract. For the purposes of the exam, it's important to know the role of salivary amylase, gastric enzymes, and pancreatic enzymes. Less commonly tested areas will include brush border oligosaccharidases and peptidases.